All right. Our goal is to finish this up today, and then probably shoot. I didn't look at the calendar. We might do like one of the FMS labs on Tuesday. Um, yeah. For now, I'll remind me to talk about that at the end of class. But if we get through all of this today, then we'll do an FMS lab on Tuesday before we get into the next thing. Be prepared, all of you right now, that you're going to slip your shoes off. You can keep your socks on, but we're going to go through some like just basic foot exercises based off of what we talked about on Tuesday and what we're going to talk about today. You'll just do it right there where you're seated, right? You'll stand up at some point as well, but just be prepared for that. Just one shoe as we go through the exercises. So looking back on Tuesday, we started talking about the lower leg. What were the four main joints that we're looking at in the lower leg area? Big toe, foot, ankle, and the knee. Okay. Going through I had the whole joint by joint approach written up here. What is the big toe supposed to do? It's supposed to be mobile. In what specific direction? Extension. So it needs to be able to extend, or if you really think about it, it's supposed to hyperextend. Okay? What is the foot supposed to be able to do? I mean, yeah, in mobility, stability, what is the foot supposed to do? It's supposed to be stable. More specifically, which direction do we want to create that stability? So we have, and I'll have some slides. That's part of the exercise that we're going to do. We have too much eversion, so therefore we need inversion. Okay, and I think I may have mentioned that once on Tuesday, so that's why that was a little bit of a tougher question, but we will do that today. The ankle is supposed to be mobile. In what direction? Dorsiflexion. Okay, so the ankle, we're stuck in plantar flexion. There's another research study I'm going to show you. Ankle, we're stuck in plantar flexion. We have to be able to dorsiflex. And then finally, the knee is supposed to be stable. I'm going to talk way more about the knee today in the sense of what do I mean by we need to have knee stability. Okay, so we finished off Tuesday talking about shoes. Okay, and we talked about how shoes we wear for aesthetic reasons, but ultimately shoes are probably doing us a little bit more harm than good when it comes to the health of our foot. Okay, we looked at how certain shoes kind of create that point, and we talked. Some of you summarized for us Wolff's law and Davis's law, but basically bone and tissue is going to adapt to the stress that you place upon it. I used to put pictures up here of the traditional Chinese foot binding, if you've ever heard of it. If you don't know what I'm talking about, I'll let you run the risk of Googling that on your own. But that was one where people already had like feet type of things when it came to pictures, and I showed that, and they were like, and I mean, it was like, okay, I'm going to skip that from now on. I'm not going to show that. Even if I warn you, I'm not going to show you that picture. But if you cram the foot into a specific space or you let the foot do what it's supposed to do, then the foot is going to look a certain way. Okay, and then we obviously had pictures on here of like high heels and Timberland shoes, boots, and then we talked about a little bit about like basketball shoes and cleats and all that type of stuff. So we finished off talking about heel drop. Can you summarize for me what I mean by heel drop? What is that? I think it was this picture. This picture. What do I mean by heel drop? This one you will need to know for the exam.
If your heel is like above the ball of your foot, you have like a high heel drop, and then like the lower your heel is, like more like flat.
Yeah. So you have certain shoes that are designed that create a little bit more of that high heel effect, where the heel is on a higher level than the ball of the foot. Okay? That difference between the level of the ball of the foot and the level of the heel, we refer to that as a high heel drop. Okay? If the heel is on a closer level to the ball of the foot, we refer to that as a low heel drop. And that obviously simulates more of being barefoot, because when you take your shoes off here in the next few minutes, your heel is on the ground, so is the ball of your foot's on the ground. Okay, but we have shoes that we wear, and shoes are, and I'll talk about that here as well. But we do have shoes, primarily, the majority of shoes are built that have this higher heel drop. So you can see, I know it's black, but the heel is up here, and the ball of the foot is down here. So you can actually see that wedge that creates that high heel drop compared to a shoe that's a little bit more neutral. So I see Wyatt back there. I can't remember the name of those. Like, they call them recovery shoes. What are the name of those?
Cane.
Cane. Okay, and what are the Ovos? I think is another brand. And then if you're like me, when I'm at home, just wearing like Crocs, seem to kind of have the same effect. Vans, Chuck Taylors. Those are kind of more of like the shoes that they're basically just flat. Then you get into more traditional like athletic shoes, you kind of create this higher heel drop. And again, there's a reason for that. But this is a study where they looked at knee stress. So they looked at individuals who wore these two different types of shoes on a regular basis. And this is just a fancy scientific term for knee stress, as well as the development and progression of knee osteoarthritis. So this is what I just skipped to the conclusion. So shoes, if you wear shoes with a heel drop of at least 1.5 inches, so that means the difference between your heel and your ball of the foot is at least 1.5 inches, okay? You have a significantly increased peak knee stress during a certain part of the walking gait. Okay, so when they say late stance, that's pretty much right when you're about to toe off. You put a significant amount of knee stress during that time. This is the same amount of knee stress that's believed to be related to the development of osteoarthritis in the knee. What is arthritis?
Inflammation of the joints.
Not so much inflammation of the joints. It's something even more specific than that, Rocco. Good guess. Even more than cartilage. Arthritis. Especially osteoarthritis. Or, yeah, sorry. No, you were right. I was totally thinking of something else. So arthritis is when joints are not necessarily inflamed, but there's a breakdown of the joint itself. Okay? The term that I was thinking of was, what's osteoporosis? That's when bones get more brittle. Okay? So if you wear shoes on a regular basis that have a high heel drop of at least 1.5 inches, you are putting the same amount of stress on your knees that's going to develop arthritis within the knee over time. Okay? Our findings show that even moderately high-heeled shoes will cause alterations in the knee joint stresses that are similar to those caused by women's dress shoes with a heel drop of 2.5 to almost 3 inches. So even if you wear a slight heel drop in the sense of increasing that number from 1.5, that is the same amount of stress that you're placing on your knees compared to wearing 2.5 to nearly 3-inch heel drops. Now again, this is a question for some of you that wear high heels. Do you feel it in your knees and your hips and your back if you were to wear those over a long period of time? Again, I don't know. I'm just asking. Kahiao, you say yeah, you feel it? Where do you feel it though? You feel it in your knees. Anyone else? Does anybody, and I'm going to get to a story here, anyone wear like a heel lift in their shoe or their cleat or their boot, like some sort of orthotic? Does anybody wear an orthotic when you play? You wear one? What's the orthotic for? If you don't mind sharing, but like, what is it?
I feel like for me, mine's just like more like a comfort thing. I think that cleats can sometimes like be too flat.
Too flat.
I feel like
Yeah.
they're too flat for me with kicking. And so then if I
Okay.
put like some sort of orthotic, even if it's not like the full length, it's like 3/4 like of the shoe, it like helps my arch on my foot a little bit.
When you say 3/4, is it from the heel towards your toe?
Towards my toe.
Okay, not from toe going back.
No.
Okay, so you are wearing something that does raise your heel up a little bit.
Yeah.
Okay. So for most individuals, this is an older research study, but women, particularly those who already have knee osteoarthritis, should be advised against wearing these types of shoes. If you go to or you talk to anybody, doesn't matter the gender, but you talk to anybody that stands on their feet a lot, what type of shoes do you think that they wear? Do they wear shoes like this one? So if you go into a hospital and you see nurse, what kind of shoes are nurses wearing? What kind of shoes are physical therapists wearing? Those that are on their feet a lot. Ashley's not here, but interning at a PT clinic. What kind of shoes are they wearing? They're wearing, like, especially physical therapists, they're wearing those shoes that have the super, super low heel drop. Okay, nurses are wearing something that doesn't have this high heel drop because, like was mentioned earlier, wearing high heels, you'll feel it in your knees and your hips, especially over time. Okay, now this story, I can't get away from this story because it has so much practicality to it, even though as each year goes by, less and less students know who I'm talking about. But it's okay, I don't care. It's still a good story. Okay, so everybody knows the Blazers. How many of you remember Greg Oden? Who's Greg Oden? For those that know who Greg Oden, who is he? Because he's pretty much non-existent at this point. Who is he? Or who was he? Okay, he was a basketball center. He came out of Ohio State. The Blazers had the number 1 pick in that draft, and they had to choose between Greg Oden and Kevin Durant. Okay? They did not choose Kevin Durant. They chose Greg Oden. Because during that time, basketball was played a little differently. It was still kind of like a big man's game. So they hitched their organization to a center and not someone who's going to go and finish as probably one of the best pure scorers ever that played. Okay? How many of you remember who Brandon Roy is? Some of you remember? Okay, who's Brandon Roy? We just have to catch up on individuals here, but we talked about Greg Oden. Who's Brandon Roy? Yep. And then he came to the Blazers. Yep. Got drafted by the Blazers and was extremely successful very, very quickly with the Blazers. Not just him individually, but as a team. They got really good. And he was before Damian Lillard. And the reason why they got Damian Lillard was because of this story that I'm about to tell you with injuries. Okay? So during this time, so we're talking like early 2010s, the Blazers were pretty good. They had individuals like Greg Oden. They had individuals like Brandon Roy. They had a very good organization. They were making the playoffs every year, which is obviously different than it is now. But this is a story that was written by Zig Ziglar, and you can see that he's a sports kinesiologist. This story was shared to me by one of my students back in 2011, 2012, because we were talking about this stuff, and he sent this to me. Tim Weiland was his name. He sent this to me. He's like, we were just talking about this in class. So that's why I talk about it every year, and I can't get away from it because the practical aspects of this story just should make a lot of sense. So fast forward, these two individuals who were superstars coming out of college, was a superstar in the NBA, had a very successful program and organization with the Blazers. The Blazers hitched their future on these two individuals, thinking that if we have this scoring guard and now we've got this big man, we can be extremely successful in the NBA. These two individuals had to retire extremely early because of injuries, which then led to the downfall of the Blazers. I mean, eventually they got Damian Lillard because he had to retire, and they got good. They were decent again, but they had very high expectations with these two to kind of take their program and organization to the next level. But they both had to retire because of injuries. Okay, Brandon Roy had to retire because of degenerative knees. Okay, Greg Oden had to retire for pretty much similar reasons. His knees just couldn't handle the stress of basketball anymore. So what happened was the Blazers general manager at the time said that he was dealing with all of these orthopedic injuries. So he hired this guy named Zig Ziglar. I believe he passed away a few years ago. But he hired this biomechanist and kinesiologist to basically run the entire team through movement assessments. Can you help me figure out what the hell is going on with these guys and why they're always getting hurt? Okay? So I'm not going to read the whole story to you, but anyway, they go down to they go down to California where this guy resides. He runs them through like all of these um, assessments, and he comes to specific conclusions about each one that helps explain probably why they're getting hurt. Okay, so during one of the dinners when the assessments was done, this biomechanist sat down with the Blazers front office and the organization and said, here are my recommendations. Based off what I saw, this is what I think needs to happen in order to keep your athletes healthy. One of the things that he noted was that Greg Oden had a true anatomical leg length shortness, meaning his right leg was ever so slightly shorter than his left. Okay, so Greg Oden was like 7'1", and he wasn't just like tall and skinny. Like he was pretty muscular in addition to being tall. So he's a fairly big guy. Kind of coming down here. I'm going to skip down here and then come back here. But his recommendation was that Greg Oden should get a special made shoe to kind of help offset that anatomical leg length. The Blazers training staff at the time said, like, bullshit, just give him a heel lift. That's all we're going to do. And Zig Ziglar was like, isn't he a Nike athlete? And Nike's like right down the road from you guys. I'm pretty sure Nike would be willing to make him a special shoe because #1 draft pick, at that time, big Nike guy. Nike can afford to make him a special shoe. And the Blazers organization said, no, we're not going to ask it. We're just going to simply put a heel lift in. So now think about this. Greg Oden, 7'1", 200 and whatever, 50 pounds, running up and down a basketball court where one shoe is normal and his right knee was like this. Okay? So if you imagine that for each of you, you have an athletic shoe on, and then I put a high heel shoe on your right leg, and I ask you guys to go play basketball, or I ask you guys to go play ultimate frisbee, or I ask soccer players to go play a regular game, and you're playing like this. I'm pretty sure that'd be uncomfortable for most of you, if not all of you. I don't think anybody's going to be able to run, cut, jump successfully when they're like this. Okay? Just like we talked about on the previous slide, the heel lift actually increases the load in the amount of anterior posterior shear on the right knee. The biomechanist told them that if you put a heel lift in, you're actually going to put more stress on his right knee and cause even more injuries. And the Blazer staff said, it's fine. It's not going to be a big deal. Just simply put a heel lift in and everything will be okay. Not the case. Fractured his patella, had micro fracture surgery on his knee, and he just wasn't the same. And he went to the Miami. He ended up winning a championship with LeBron with Miami, but he was the guy that sat on the bench. Like, he didn't even play, but he was on the team. So his career was derailed basically because you had professionals within the Blazers organization that didn't want to listen to an expert in movement analysis. Okay, obviously that management, they went away very quickly. They brought in a new, his name was Chris Stackpole, physical therapist that came in as the new director of player health and development. And then that's when they got good again with Damian Lillard and all that type of stuff. But what I wanted to share with you here is a practical example of how simply putting in a heel lift can create a lot of knee stress and knee torque. So if you think of your tibia, you think of your femur, okay? So my fist is the knee joint, okay? So if I have a heel lift, what's happening is my femur is going to get driven down this way. So instead of your knee kind of sitting like this and then moving here, your knee is now sitting like this. So when we talk about anterior posterior shear, this is what we're talking about. So when you're wearing a heel lift, your femur is getting driven down to the front of your knee capsule. And on the front of your knee capsule, you have your patella and your patella tendon, which is what happened. There was so much stress being pushed this way that it fractured his patella, and he wasn't the same at that point. because the Blazers organization thought they would just save a couple bucks and just put a heel lift in when, again, at that time, Nike would have bent over backwards to make him a more specialized shoe. Okay? So I talked about this on Tuesday, but there is something to be said. I don't have research yet to back this up, but there is something to be said for your bare feet to touch a variety of different surfaces for the sake of movement capabilities, but as well as health. Okay? Every surface that you walk on, whether it's carpet, whether it's concrete, grass, hardwood, rubber, like the rubber flooring in the weight room, they all have a different type of vibration frequency. Okay? Because you have thousands of sensory receptors on the bottom of your feet have to be able to be accustomed to different levels of vibration frequencies. Because then that is going to give you the perception of how your body needs to adjust in order to not only maintain balance and stability, but then to be able to move the way they're supposed to, in the sense of big toe doing what they're supposed to do, the foot doing what it's supposed to do, the ankle, the knee, and eventually up the chain. Okay? I have heard a lot of anecdotal evidence from strength coaches, personal trainers, and physical therapists how movement capabilities have changed as soon as they got people out of their socks and shoes and had them start walking on uneven surfaces or just standing on uneven surfaces. Okay? So walking through rocks, walking through grass, having the AstroTurf outside or the field turf kind of touch the bottom of your feet, walking on concrete, walking on hardwood. They said pain slowly went away over time because these receptors were woken up again, and it can create that proprioception of what the toe, foot, ankle, knee, what they're supposed to be doing when it comes to movement capabilities. So this is something simple that you all can try for yourselves, as well as if you're helping other people, you eventually go through grad school, become a physical therapist, chiropractor, athletic trainer. Let's try getting you out of your socks and shoes more often and have you start walking on uneven surfaces. Okay. Again, I don't have research yet to back that up, but I have heard a lot of stories of how that has helped. Okay. Any questions on the foot, especially when it comes to heel lifts? I'm looking at some of you. Birkenstocks, that's nice and flat. Air Force Ones are pretty clunky. Heel drop isn't too bad. I have a lot of those Air Maxes that Tiani has. Those are very much like this. If you've ever felt them, the heels are super, super thick. Are those Hokas? Those heels look fairly thick as well. Why do you think shoes are made with a heel drop or a high heel drop? Why do they, if people know, and these people know, they know that a high heel is not necessarily good. But why do they do it then? Birks, those Uggs. Are those just Adidas running shoes? I'm just looking at everybody's shoes now. What's Gavin got on back there? They're running shoes. Why do they make them? Why are shoes made with a high heel? Not just high heel shoes, but just even athletic shoes. Why are they made with a high heel?
Does it help with running? And like if you're running like long distance or something, like pushing off like the back you're putting
Yep.
your toes.
So there is a biomechanical performance aspect to having higher heel shoes. In that situation, if you look at some running shoes, I think yours might be one of them. Yeah, you can kind of see Gavin's shoe, but it's almost built like a U in a kind of like this, because that's going to help with the heel strike and then eventually the roll into the push off. So yes, having a high heel drop, especially with the way the shoe was built, it can help with just propelling someone down the street during a marathon. It just makes them more efficient. Why else do you think shoes are made with a slight high heel? I don't know if you guys ever knew this. But having a shoe that's higher up, we talked about the ankle needing to be able to dorsiflex. Again, what does the foot have to be able to do? Has to be stable in which direction? We need to create more inversion. Having a shoe with a higher heel drop actually creates a little bit more stability within the foot. Okay? So having a higher heel drop creates a little bit more stability in the foot to basically help promote a little bit more inversion. But that also comes at a cost. Because the higher our heel is, the more we're going into plantar flexion, which we are already stuck in to begin with. And then in addition, if that heel is too high, like we've just been talking about, it's going to put a lot of undue stress and torque on the front of the knee. Okay? So that is the dilemma that shoe developers have to come up with. We need something that's going to help them with movement. It's going to help them with their performance. I think Nike developed a shoe that helped someone run the marathon in under like 3 hours, like 2.5 hours, that they had to ban it because it was such a performance enhancement that the non-Nike folks are like, it's not fair. Like, how come they get that shoe and we don't? So they need to develop something that helps with performance and the mechanics of the movement. They also have to find a way to create stability and mobility where they need to be, but it's hard to develop something perfect in that regard. That's why a lot of people, like a lot of podiatrists will actually say one of the worst things that you could wear would be something like slippers, because there's absolutely no support whatsoever. But then we can argue, but you're letting the foot do what it needs to do. But in their eyes, like there's not enough stability there to help, help with performance. So you just answered my question. The foot's supposed to be stable. This is the common issue that we have with the foot. It's called excessive pronation, overpronation. It could be called like navicular drop because the foot drops this way. Weak feet. Okay, now, yeah, flat foot. You can't have a flat foot and have a strong foot, just like you can have a high arch and have really weak feet. So just because you have a high arch does not necessarily mean that you have a strong foot. Just because you have a flat foot doesn't necessarily mean you have a weak foot. You can still find ways to strengthen both, even though you may not necessarily be in that position. But this is the position that we want to see. So if you look at the ankle from the posterior view, we want to see a nice straight line. Unfortunately, this is what we see. How many of you know that you wear your shoes out like this? Like the inside of your shoe gets worn out. Ashlyn, you're one. Anyone else? I know I am. You are, Logan. The inside wears out more than the outside. So that's a sign of that excessive pronation. What we have to have is we have to have a balance between your inverters and your everters, which most people refer to as a stirrup. Okay, so if you ride horses, you slip your foot through the stirrup. We have a stirrup that runs around the foot that if this is tight and this is weak, it's going to create this excessive pronation. Okay, so if I want to fix the foot, I need to lengthen the everters and strengthen the inverters. And we're going to go through some exercises here in the next few minutes. Okay, if I want to fix my foot stability, one way to do that, because this side is overly tight, I need to relax this group and lengthen them. If I'm in this position, this part of my foot is weak, I need to find a way to strengthen them. So going back to all the neuromuscular stuff, what do I do on this side to shut these muscles off? What sensory receptor do I need to get to turn on this side? GTOs. What do GTOs cause the muscle to do? And once they relax, that's the best time to lengthen them. How would you make the GTOs turn on in a situation like this? Foam rolling, massage. Okay, so foam roll this side of your ankle. And then what we're going to get into then is then how do I activate this side so that I can go from this position to this position here. Okay, the foot's supposed to be stable. It's too sloppy. When we say it's too sloppy, we have too much of this. So we need to get the everters loose, the inverter strong, so we can get to this here. Okay. Oh, I thought I guess we're not going through the foot stuff just yet. Well, I know why, because it's all related. What is the knee supposed to be able to do? B. What is the knee supposed to be able to be? Okay. So let me get into the specifics of what I mean by knee stability. This is normal. What do we call this? Bow-legged, right? So layman's terms, we refer to this as bow-legged. What is this? knock-kneed. Okay? This is what the knee position we're striving for. These are abnormal knee positions to be in. Scientifically, or layman's terms, bow-legged, knock-kneed. Scientifically, do you know what we call this? Varus valgus. So when we talk about the knee being stable, that means we want to create stability within the knee so it's tracking straight. The common issue we have with the knee is that it's unstable and it's stuck in this position here, which we refer to as knee valgus. So the knee is supposed to be stable. We need to stabilize it from frontal plane-based movements. We have too much of this. Okay? So later on, we're going to talk about squatting. When we squat, we see too much of the knees coming together. And there's a reason why they come together. So when we talk about knee stability, we need everything tracking straight and not going this way and not going this way. But the most common is this one. You see this one from people who obviously ride horses a lot. But this is the most common knee instability issue that we see here. And there's reasons that we're going to talk about. All right, I want you to watch this video. Next Tuesday, we're going to do the functional movement screen, or at least introduce the functional movement screen. Gray Cook, Lee Burton, Brett Jones. It's like a team of athletic trainers and physical therapists that came up with the functional movement screen. This was the video that Gray Cook, the physical therapist, saw that said, we need to do something about movement capabilities or how we can measure movement. So this is an individual that is coming off an ACL injury. I mean, it's an old video, 2003. You all get hurt. When are you able to go back and play? Who has to clear you? Doctor. Doctor then tells the athletic trainer they can go in and play. So the medical doctor has to clear you to come back from a major injury, like an ACL. This teenage basketball player was cleared to go back to play after ACL injury. I want you to watch this video and then you tell me if you think she's ready to go back and play. Okay. Yeah, then there's this guy too, but whatever. He's got his own issues because he's dominant on his left. Okay, watch this again. Okay, does that look like she's ready to go back and play after an ACL injury? Doctor said she was ready to go back and play. And that's when Gray Cook was like, this can't happen. Because in the grand scheme of things, what's probably going to happen to her if she goes back to play? She's going to get hurt again. She's going to hurt the other one, which we've all seen before. Because they're looking for two things, range of motion and strength. And when they look for range of motion and strength, they look at it at a very small scale, handheld dynamometer, goniometer, but they're not looking at it in a more functional view of her being able to squat, step, lunge, all that type of stuff. And that's when they developed the functional movement screen again, which will start next week. Okay? So, okay, I want everybody to do this with me. Take your right sets of fingers, piece up, A-town down. Okay? You're going to take your middle finger and put it in front of your index finger so you're making a cross, or an X, I should say. Okay? Now take your left hand, and I want you to surround your two, so they're crossed, surround those two fingers like this. Okay? This is your knee capsule, ACL, PCL. Cross, that's usually how they sit. So they think of this as my femur, and then this is the joint capsule itself, or the tibia. Okay? So remember, this is your right side. This is your right knee. I want you to twist your femur in both directions and tell me which direction do you feel the two ligaments getting tighter and more stable? Is it this way or is it this way? Which one feels tighter and more stable? Going this way. Going back to the first week of the semester. If my femur, the front of my femur faces outward, what hip motion is that called? External rotation. If you want to help your ACL be more stable, you got to be really good at externally rotating that femur. When your knee is unstable, you're going in this direction here. Okay, so being in this position where this front of your femur internally rotates, you're creating a much less stable position for your ACL. And you think about when most people get hurt from ACLs is what? When they plant and that knee kind of comes this way and then they try to twist on top of that. Sorry if I'm bringing back PTSD for anyone that, or their ACL. Kahiao, you were one, right? How did it happen? Oh, so yours is different. Yeah. The only way to avoid that is just to get off the soccer pitch. Be like, I'm not playing. Okay. Anyone else? Was there someone else that tore their ACL? Yeah. So we have to find out how she did hers. Okay. I'm going to skip through this right now so we can get to some of these exercise videos. All right. So everybody take your, it doesn't matter, right shoe, left shoe. You can keep your sock on. So when we talk about the foot, which movement do we want to try to replicate? Or not replicate, what movement do we want to do in order to keep our foot stable? We want to invert, okay? We want to get out of eversion and we want to invert. The way that we can, I mean, you all know that there are exercises to practice inversion. If you ever sprained your ankle before, you probably did a bunch of like towel exercises. Those are, I mean, by all means, those are really, really good too. This is something more specific to the actual foot and going from an everted foot to an inverted foot. And they're called short foot exercises. You literally are trying to make your foot shorter. So if I actually come back to this, if you all put your feet flat on the ground and just relax it. So do that right now. Just put your feet flat, just sit there and keep it nice and relaxed. Okay, so you've got the length of your foot from the ball of your foot to your heel. A short foot exercise means you're going to try and scrunch the two ends together and contract all of the muscles in here. Okay, for some of you, that's going to be a very isometric muscle action because you might already have a high heel arch. So you're just literally contracting those muscles to create that short foot. If you have more of a flat foot, it might be more of a concentric where you'll actively see your feet come together. So we're going to go through a progression of these short foot exercises. The first one is going to be seated, non-weight bearing. So you're going to sit on the edge of your seat, just like this. So you've got 90-90, and the first one's going to be, he's going to go through it, but I'll mention it now. The first one's going to be non-weight bearing. The second one's going to be weight bearing. And then the third one, you're actually going to stand up and do this. Okay? But these are all referred to as short foot exercises. Well, let me back up. No, the first one he's going to do to the patient. Like he's going to grab her foot and just crank on it to make it short. That's the first one. You don't have to do that. The second one is going to be active non-weight bearing. The third one's going to be active weight bearing. And then the fourth one is going to be, should be standing up. Okay? Let's watch it. Go through it. Okay? So this first one, she's going to relax. This is going to be passive, where he's going to basically give her the feel of what a short foot is. So he's bringing the ball of the foot closer to the heel. Okay, so if you have someone that can't neurologically turn that on, now everybody try that. Sorry, there's no sound. Do I kind of pause this? Okay. If you do this, I don't know if you saw it the first time. When she did this, did you see the ball of her foot come up off the ground? We don't want that to happen. When we talk about pressure on the foot, we have what we refer to as a tripod. The ball of the foot, so underneath the big toe, underneath the pinky toe, and the heel. Those 3 points should be in contact with the ground the entire time. So even as you slide your feet together, that big toe shouldn't lose contact with the ground. You're doing something a little bit different. Now, for some of you, you might be trying to move your foot and it's not happening. That's a sign that you probably need to spend a little bit more time doing these intrinsic type of foot exercises, okay? So he's going to keep going here. Oh, crap. Okay, so we'll just keep going through that. So watch her again. You'll see this come up off the ground when she tries to do it herself. See that? Lost contact. We don't want that. All 3 points are happening, and go ahead and try to actively create that arch. Try not to pick. So some of you are curling your toes. That's not the same thing. Your toes are flat, and you're simply just bringing the ball of your foot to your heel. So now it's going to be weight bearing. So this is just a progression. So she's doing a little bit better. You can see that contraction through the middle of the foot. Again, trying to give her the tactile cue of what that short foot's supposed to happen. And then now she's going to go weight bearing. So go and everybody stand up and try that. And then we'll stop the video. Yeah. So no curling of the toes. Don't lose contact with the big toe. You're simply just sliding your foot. It's easier for me because I'm flat-footed too. Okay. So it's here without doing this or losing that contact with the big toe. You just simply slide it, and then can you hold that position, especially as you put more weight on it. Okay, so do like 5 of those reps and just create that short foot. Again, you're thinking the middle of the foot, that's what's going to be contracting and holding that position. You're not simulating, you're creating more inversion of the foot and less eversion. And if you do it right, you should feel it in other parts of your body too. And if you're doing it right, you tell me where you might be feeling it besides just your foot. What do you, Marco, what are you pointing at? You should feel it right here if you do it right. Okay? Once you do your 5, you can go and sit back down, because then we're going to go through some other ones here. Okay? So, you creating that short arch. The reason why creating that short arch is important, because again, which direction created more stability in the knee? Internal or external? It's a chain of events. When that foot goes into inversion, your femur goes into external rotation. So that's why if you do it right, you should feel it in this muscle group, because this muscle group is working to externally rotate your hip. Okay? These are stupid exercises that you can do just while you're sitting down watching. You can obviously do it standing. Again, just very, very subtle exercise to help strengthen your feet. Here's another one. This is a long video. We're not going to go through the whole thing, but just try this out. I know you have socks on, so your toes aren't going to be able to move as freely, but these are just exercises to give you a sense of what are some of these intrinsic muscle types of exercises. Oh, what the heck? There we go. Here we go. Okay.
Strength and control.
Nope.
Make them stronger. So what you're going to notice.
Okay, let's go through the
4 toes against.
Okay, here we go. Try this one first.
Exercises that I'll prescribe is actually the first thing I'll use in terms of assessing for intrinsic foot control. What I'm going to get the patient to do is I'm going to get him to plant the lateral 4 toes against the ground as hard as they can. So if you look at this foot here, we're planting the lateral 4 toes. And then what we're going to do is we're going to get him to, or her to, slowly lift the great toe as high as they possibly can. Now,
everybody try that.
when we say as high as you possibly can, you want to extend as far as possible. And what you're going to notice in people who can actually accomplish this is they're going to start to get cramping on the inside of their foot here, as well as on the outside of their foot here, and sometimes in their extensor glutes. Now, I always explain to patients that cramping is simply neurological confusion, or it's the inability of the nervous system to really produce the movement that you're asking it to do. So I'll really get them to fight through the cramping and just kind of.
Anybody cramping?
And they'll notice that the pain will.
A little bit.
The next exercise we'll do is the exact opposite.
So try the opposite now. So plant the big toe, and you're going to lift the 4
into the ground as hard as possible, and then lift the lateral 4.
It hurts?
Touch
Jill, are
the
you
big toe,
okay?
extend the lateral form. Once again,
Oh, you have to. Oh, that doesn't. How many of you have had turf toe before? That hurts like that. That's extremely
In
debilitating.
most cases, when you ask someone to do these,
Does this
they kind of
help?
stare
Like,
at their foot and
doesn't
you'll see
aggravate it, does
flickers
it?
of contractions like that, but
You just
nothing
can't
will
do
actually
it.
occur, and that's really
Yeah.
not an uncommon finding.
Is one of these easier for you than the other? Which one's the easier for you? The 4 coming up or the big toe coming up? Big toe coming up. So the other one's a lot more difficult to plant the big toe and then pull the 4 up. Okay. I think let's go. He's got more, but let's go through some of
this particular exercise. The answer is as many times motion.
So that's a way to kind of regress it. It's just to hold your big toe down.
We're going to work on is, or the next movement that we're going to work on is the ability for the toes to adduct. Of course, adduction.
Okay, this one, I'm going to skip through this one. I'm going to show you this one.
Straight as they hold. Adduction.
Okay.
What we're going to do next is work on adduction,
this one,
which is actually considerably more difficult and will take them a lot more time. So what we're going to do with the foot flat, we're going to get them to simply extend all of the toes, keeping the metatarsal heads down. And then from here, we're going to splay the small toe, then the next one, and the next one, and the next one, going towards the big. And we're going to get them to plant them one at a time on the ground. So raise up, keeping the heel on the ground.
So bring it up, splay it, and then put it down pinky toe first.
Raise up, and then separate the
Oh,
toes.
good. Logan, good job.
Small toe down.
Very good.
The next digit, and then the big toe. Stand up. Extend or expand, adduct, plant, 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 plant.
Okay. Was that hard? Easier? A little harder? Can't even do it. Okay. It just shows you that you all, not you all, but most people, how do I advance? Need to do more work with your feet, and that you need to strengthen your feet. And in the grand scheme of things, no one can be blamed because we wear shoes when we walk to class. When you play your sport, you have to wear certain type of footwear. So that means that you all, everyone in general, needs to have a little bit more attention spent to what your feet are actually doing, what they can do. At the Rise Lab, I'll put like everybody knows what a battle rope is, the battle rope thing. So I'll put that out like in a certain shape or snake, and I'll make the high school, middle school athletes take their socks and shoes off, and they'll walk on the battle rope like it's a balance beam. So you can imagine that as your foot hits the battle rope, it kind of curls over the rope itself, and it gives them that texture feeling underneath their feet. So during the warm-ups, we'll spend like 2-3 minutes just doing like barefoot stuff, just to kind of get them out of their shoes, if anything. Okay. This is an example of the chain of events that I'm talking about. Okay. How many of you have flat feet again? Have you had any issues with flat feet? I think I asked this on Tuesday. What kind of issues have you had with flat feet, Tiani? Oh yeah, that you had mentioned that on Tuesday. Marco, what was yours? So it shows true foot problems. Okay. This gets to the whole joint by joint approach that I talked about. Okay, that if one thing is off, it's going to affect the rest of the chain. If my knee hurts, where should you look? Above and below the joint. So before my family and I moved from Illinois to here, to Oregon in 2011, I was playing in like a church league, like softball league, just super like informal. And after like a week of practicing and playing, I saw a gnarly collarbone break during that time. That was pretty cool. I think I freaked them out, but it was really, really cool. After about a week of practicing and playing, like both of my knees like swelled up dramatically, and it hurt really, really bad. And I didn't really know what was the cause. I had knee issues when I was playing at Pacific, but it wasn't to this like extent and severity. So we're about 2 months away from moving. So this is like spring, kind of around this time, spring, going into the summer. And my knees were so swollen and achy. I went to my athletic trainer professor, kind of like Emily, the equivalent of Emily at Northern Illinois. I was like, Bill, can you look at my knees and kind of figure out what's going on? So he sat me on the table. The athletic trainers do their business and, grabbing my foot and doing all that. He's like, and he was like trying to feel where it hurts. He's like, I think you tore your meniscus. I was like, oh crap. Moving in, what's the plan for that? He's like, well, you could have surgery. You need to have an MRI, figure out the extent of the damage. So if you have to have surgery, you can. I'm like, oh my God, I'm about to move. I've got like a 3-year-old and a 1-year-old. Like, how the hell are we gonna do this? So I go get my MRI, and they call me back, like a week later. And I remember I had my oldest daughter with me at the time. She was only 3, but she came with me to the doctor's appointment. And the doctor said, your MRI actually looks really clean. Like everything looks really good. Cartilage looks good. Ligament looks good. And then he said, when you walked in, I actually thought you tore your ACL because of how swollen my knee was. He was like, usually I see swelling like that when there's a torn ACL, something more severe. So he's like, it was none of that. But my knee was still super, super swollen. So my daughter, to this day, she still remembers them draining my knee. She probably shouldn't have been watching, but they drained my knee. So they pulled out all this, like the yellow liquid. They just pulled it all out, and my knee felt so much better because of all that pressure. She still remembers that. So the doctor, to his credit, like he didn't just like say everything looks good, get out, like most doctors do. He sat down and talked, like explained to me, like, give me the history of like knee issues, give me the history of this. Have you hurt your ankles, blah blah blah. And then he was like, okay, take your socks and shoes off. I want you to walk down the hallway, and I want you to walk back. So I did that. And he starts going after like my feet, just like looking at it, like doing all these tests with my feet. And he was like, man, have your feet always been this flat? I'm like, yeah, go to the beach in Hawaii. Everybody knows where I went because it's like a rectangle in the sand. They're like, yeah, my feet have always been flat. And he was like, I think I know what your issue is. Like, I think your feet are so flat. It's like a joke, right? Your feet are so flat that what's happening is your tibia is turning inward. Okay, so internal rotation of the tibia. Okay. In order to maintain the joint congruency of the knee, if this rotates inward, what does the femur have to do? Rotate inward so that it follows the tibia. So because your feet are so flat, tibia is internally rotating, femur's internally rotating, your kneecap is sitting on the outside. So when you were playing, even dating back to college, whenever you would run, so flexion extension of the knee, your knee was doing this, and your patella just sat there. So in the grand scheme of things, your patella was doing this every time that you would run. And you can imagine the irritation underneath the kneecap, which is what explained why my knee got so swollen and painful. So he says, so what you need to do is you need to figure out a way to strengthen your feet and or strengthen the outside of your hips, the external rotators. So instead of me running constantly like this, because my feet were so flat, he actually said what you need to do is strengthen your feet and strengthen your hip. So now your femur is in this position here, where your kneecap wants to sit. And to this day, I give him credit because he easily could have just been like, everything looks good, keep doing what you're doing. But it's like, but I still have this issue. Like he sat down with me and walked me through the entire thing. And of course, once he explained it to me, I was like, that makes so much sense now. Even back to my playing days, it makes so much sense why I had so many knee issues. Because what did they do in the moment? My knee hurt. What did they do? They focused on what? The knee. Ice your knee. How many of you have worn like those patella tracking straps? I don't know if you know what I'm talking about, but I had to wear those. Did they look at my feet? Did they look at my hip? Did they look at my core? No, they just dealt with the issue, which didn't help me at all when I played. So now I knew. Okay, does that make sense? Kind of that chain of events, joint by joint. Okay, here's some research. How many of you deal with knee pain on a regular basis? Like, it doesn't have to be major, but like anterior knee pain. Anybody deal with that? Jumper, right? Is it just from catching, I'm assuming? Just constantly being, aren't you guys taught the whole kneeling thing now? Do you guys do that? You do put a knee down? That's like the thing now. You're still, but it hurts from obviously squat. That's just a lot of repetition of being in that deep squat. Because when your knees are fully flexed like this, and then you squat in that fully flexed position, that puts a lot of pressure on the front of your knee, so it should make sense. Anybody else? Jumpers, runners, sprinters, you got anterior knee pain? Just full-blown knee pain. Do you know why? Oh. Both knees or one? Oh my God, really? Oh, I'm sorry. Yeah, that's not fun. Does it bother you when you play, when you're in the moment playing? Does it bother you, or is it more like after? Both. Really, just kind of have to deal with it. Yeah, it sucks. Basketball. These types of injuries are very common. Jumper's knee, if you've heard of it, which is kind of like Osgood Slaughter's. You know what have you heard of Osgood? That's more genetic and development. But when we're talking about patellofemoral pain, the reason why I'm talking about patellofemoral pain is this is one of the more common knee injuries you're going to deal with because it's just nagging pain. There's nothing major that's wrong with it. The patellofemoral joint is just irritated and inflamed. But it's not enjoyable because it's extremely painful. Okay? What's the issue with patellofemoral pain? So, what we see here in this research article, a lot of numbers here, but don't worry about that. The biggest thing that they are concluding from this research article is that they looked at all of these researchers and they looked at the strength of the hip of the leg that's hurt and the strength of the leg that's uninjured. If you look in this red box, you see all these negative signs. That means the hip strength on the injured side is significantly less than the hip strength on the uninjured side. Okay? Now, when I talk about strength, I'm going to give you 3 specific motions that's leading to knee pain. That if you can strengthen those 3 positions, you're on your way to helping that individual get over their specific knee pain. So this first article is just to show you the affected side, usually the hip is weaker. Okay? Athletic training research here. So now they took it a step further. These individuals took it a step further, and they took a group of people with this patellofemoral pain and said, let's put you through a specific training program or rehab program to see if we can remove your pain. So what they did with half of their subjects, the people with pain, they had them do these stupid exercises. And I say stupid because they're just single joint, kind of like warm-up based exercises. What is this hip motion called? What? Okay. What's this one? Extension. It might be hard to see for some of you, but her toe is facing straight here, and now her toe is facing outward. So not only are they doing extension, but they're also doing what? External rotation. I think you know where I'm going with this. The group that strengthened their hip muscles, at the end of it, where is it? Reported significantly less pain. Okay, so this is an analog scale where higher the number, that means it's more painful. It's just stupid. Like on a scale of 1 to 10, tell me how much it hurts. Statistically, their amount of knee pain went down from simply strengthening their abductors, their extensors, and their external rotators. That's it. Okay? So what did that medical doctor have me do? That medical doctor had me do a lot of, how many of you have done these before? You put like the little bands around your knees, and then you have to like walk like this. Or the one that he told me, he gave me a different name, but I just call him Stanky Leg. He had me do like this thing here. And then the other one he had made me do is I had to stand on one leg. So now you've got some footwork, foot strengthening. And I have to do this with the mini band. I mean, you talk about burners right here. If you've done those burn. But that's what he had me do because he was trying to get me to improve my abductors, external rotators, and extensors. And he even asked me, again, to his credit, he asked me, what's your favorite exercise? Like when you lift, like what's your favorite exercise to do? And at that time, it was like, oh, back squat. Like, oh, love back squat. And he asked me, like, do you do any like deadlifts? And I'm like, no, not too much. He's like, maybe do some more deadlifts and do less back squats. Because like we're going to talk about, this is a lot of knee. He wanted me to do more hip. And as soon as I started doing that as well, my knee pain slowly started going away. So that's why I give him a lot of credit. Okay, I'm going to skip through some of this stuff here so we can get to this because I want to finish this up so we can get to our the heck. Okay, so we're going to finish up with this. Got about 15 minutes left. All right, so the last part of each 4 of these presentations, we're going to talk about specific movements. When you're talking about human movements, especially in the sense of rehab and training programs, when you're designing a lifting program, it really comes down to 6 movements that you see here. Okay, if you do these 6 movements on a regular basis, your program is going to be very well balanced. If you focus on a few of them too much, it's not as balanced. But again, for me, I probably need to be spending less time doing one of these because of my knee pain. Okay, what do you think this motion is called? So baby doing this. What is this called? It's called a push-up. So one of the main motions, the human movements we have, is called an upper body push. Pushing something away from you. Okay? If this is a push, what's this one? A pull. So it's kind of simulating a chin-up. Okay? So if I take an object and I'm pushing it away from me, we refer to that as an upper body push. If I take an object and I'm pulling it towards me, we call that an upper body pull. Okay? What do you think this one is? Not running. Well, yes, they're running, but not running. They're holding something. We refer to these as loaded carries. That is a fundamental movement pattern. You pick something up and you walk with it or run with it. Okay? So some of you probably did your Easter egg hunts on Sunday. You're probably running around looking like this, putting Easter eggs. Just me? No one else? Oh, I mean, okay? Eat my kids' candy. What's this one? Don't overthink it. What's the baby doing? Rolling. We're going to do some rolling patterns in this class because it does something neurologically for reflexive core control. Dead serious. Okay? That's another one. Now let's finish up with these two. What's this one? Lower body pull close. We call this a hip hinge. So if this is a hip hinge, what is this? Knee hinge, or otherwise called a squat. So the 6 basic movements for training and rehab: upper body push, loaded carry, roll, upper body pull, hip hinge, and a squat. Okay? Because we're talking about the toe, the foot, the ankle, and the knee, which movement do you think we're going to talk about here in the next 10 minutes? Which one of these? Squat. Let's talk about the squat. Okay? How many of you have heard, I don't like squatting because it hurts my knees? Did you say that, Rocco, or have you heard that? Caleb? You heard it? Is anybody going to admit that they're one that says, I can't squat, or I don't squat because it hurts my knees? Anyone? No one's going to admit it? Oh, there we go. Well, you do have a situation where maybe squatting is not the best for you. Okay? So if you've heard this outside of certain people, it's not because of the squat motion, it's how they're squatting that's hurting their knees. Okay? The way that we define a squat is maximal bending of the ankle, knee, and hip with an upright torso. Okay? The definition of a squat: maximal bending of the ankle, knee, and hip with an upright torso. That is a squat. That is different than a hip hinge, which we'll talk about when we get to the hip complex in a couple weeks. Okay? Maximal bending of the ankle, knee, and hip with an upright torso. Now let's be a little bit more geeky here. When I talk about maximal bending of the ankle, what specific quote-unquote bending needs to happen in order to do a squat properly? Dorsiflexion. Maximal bending of the knee. What are we talking about? The knee's got to be able to do what? Flex. Maximal bending of the hip. The hip has to be able to do what? Flex. So when we talk about maximal bending of the ankle, knee, and hip, that means ankle has to dorsiflex, knee has to flex, hip has to flex with an upright torso. Okay? So these are pictures of my 3 kids at approximately the same age, and obviously point in time. Okay? You may not believe me, but I did not coach my kids on how to squat and hip hinge. None of you were coached on how to squat and hip hinge when you were toddlers. But if you look at some of these positions, outside of my son, but you see maximal bending of the ankle, knee, and hip. So, I mean, this is a better picture. But you see how little Kenna's knee is coming out over her toe? So you've got dorsiflexion. You've got maximal bending of the knee. So little Kyla here, bending at the knee. Maximal bending of the hip, little Cullen, with an upright torso. That's a squat. Feet are flat. More specifically, heels are down. If you see people squat and they say, well, I don't like to squat because my knees hurt. And then you see this, that's why your knees hurt when you squat. Because there's something that's limiting you, that's not allowing you to give you flat feet, dorsiflexion, flexion, flexion with an upright torso. Okay? So what is that limitation? What are the common limitations? The common limitation that you see in a squatting pattern is the person's inability to dorsiflex. That's it. They can flex their knee. They can flex their hip. The fact that they can't dorsiflex, they look like this when they squat. So on Tuesday, when we do the functional movement screen and we go through the overhead squat critique, the general cue that you're going to give each other, that I'm going to give you, heels down, or when the dowel in position, chest up and heels down, squat down as far as you can, hold it for a second, and then come back up. And as soon as I give you those cues, some of you might be like, I don't know if I can do this. And then you perform it and you do this when you squat. And that gives you a lot of evidence of like, I think this is what your issue is. For most people, it's the inability to dorsiflex. How many of you have heard you're not supposed to let your knees go over your toes? Have you heard of that before? Why have you heard that? Like in what regard? What was the situation? For what specifically? Like what were you being taught, or when you're squatting? When you're squatting, right. So when we're squatting, again, our heels need to be in contact with the ground. In order to squat, our knees have to be able to track over our toes. There's no way that you can squat and keep your knees behind your toes. You're turning it into a completely different motion. So if I were to squat here, but I let my knees track over my toes, but if I don't let my knees track over my toes and I try to squat, now I'm doing this. What is this called? We'll talk about this in a couple weeks. That's a hip hinge. You've changed the exercise into something totally different at that point. With squatting, you have to let your knees go over your toes. Try walking up the stairs without letting your knees go over your toes. You're going to fall backwards. You're going to be like, there's no way that you could physically do it. You have to let your knee track over your toe, which means you have to be able to dorsiflex your ankle. If your ankles don't dorsiflex, how many of you have seen people do this when they squat? Anybody seen that? So you see someone squat and their feet rotate out. They do that because their knee can't track over their toe. How many of you have seen this when people squat? That's pretty common. That's a sign that they can't dorsiflex. Here's the last one. You see that? You see the heels come up. That's a sign their ankle can't dorsiflex. Because if their heel can stay down and they can dorsiflex, if they can dorsiflex, their heel will stay down, their chest will stay upright as they squat. Okay? So for most people, the issue is dorsiflexion. And there are ways that we can allow them to cheat so they can still do the squat properly and be safe. We'll demonstrate that on Tuesday as well with the FMS. Okay? So this is the last slide. How many of you squat with shoes on? How many of you squat with no shoes on? Okay. Why do you squat with well, let me ask that again. How many of you squat with like squatting shoes, like Olympic lifting shoes? Ashlyn, you do? That helps you? They're meant to help you squat. How many of you, when you squat barefoot, why do you squat barefoot? But are you back squatting? No. Are you front squatting? You front squat barefoot? That's even harder. That's even harder. What are some squatting exercises? So I mentioned back squat, I mentioned front squat. What are some other ways that you all squat downstairs? Goblet squat. It's another one. Split squat. Pistol squat. No one's mentioned my favorite yet. Yeah, baby. Rear foot elevated split squat. Anybody know that one? Do that one on a regular basis? Unfortunately, you don't like those? Oh my God. What? Do you know how good they are for you?
Yes, and it hurts a lot.
That's why they're so good for you, and that's why they hurt. What are some other ways you can squat? Have you heard of Zercher squats?
Yeah.
What's that? What's a Zercher squat for those that don't know?
Hold the bar right
Yeah.
there.
So back squat, the bar's here. Front squat, the bar's here. Zercher, it's here. It's just a front-loaded squat. Split squat, rear foot elevated, pistol squat. Anybody know speed skater squat? Pistol, you come out this way. That requires a lot of dorsiflexion. A speed skater squat is this way. So the leg just goes back and you go all the way. I probably shouldn't do it on my repaired tendon, but you go, Jesus, all the way down and then you stand back up. That's a speed skater. Those are all different types of squats. And you think about the definition, maximal bending of the ankle, knee, and hip with an upright torso. Okay, those are all squats. The thing I just want to mention here is when you're squatting, watch your big toe. Don't let a common mistake is a big toe will come off the ground. Head of the first metatarsal, fifth metatarsal, and heel, those all need to be cemented into the ground when you squat. Okay? So on Tuesday, you all need to wear shorts, t-shirt, and we will be doing the majority of our squatting and measurements with your shoes off. So if that means you need to clean your feet or whatever, trim your nails, whatever you need to do, you will be walking around the upper gym barefoot on most of the occasion. So be prepared for that. I will put the lab handout in Blackboard. There's nothing for you to do prior to. Just be dressed and mentally ready to do some squats, and we're going to measure your ankle dorsiflexion as well. Okay? So we'll do that Tuesday, and then we might start the hip on Thursday, and then we'll do some exercises and lab stuff with the hip as well.
Are we meeting?
Let's meet here. Let's start here, and then we'll make our way. Oh wait, no, shoot, we might have to go to the field house because all the FMS kits are there. We'll figure it out. Me here, just me here. Steve, hold on for a second. Do you have an iPhone?
Yeah.